Hello and welcome all to another session of metabolism. Today we are going to be discussing about triacylglycerol metabolism and fatty liver. So, a small introduction into adipose tissue, but the actual part of adipose tissue will be covered when we are looking at obesity. So, that is another session, but here let me just introduce you to types of adipose tissue. So, this is a specialized connective tissue which functions as a major storage site for fats, and fats are stored as triacylglycerols. So, there are two types of adipose tissue, the white adipose tissue and the brown adipose tissue. So, here we can see the white adipose tissue. This is the white adipose tissue. Unilocular cell, there is a large lipid droplet that you can see here, and it is almost pushed the nucleus to one side, and you can see a few mitochondria. Now, in contrast, brown adipose tissue has more number of mitochondria with comparison to white adipose tissue, and the lipid droplet is not one big fat globule. Instead, it is broken down into smaller globules or smaller droplets and stored. So, what is the content in adipose tissue? We have some amount of water and proteins, but majority of it is going to be lipids, and this in this 90 to 99% is going to be triacylglycerols. Another small percentage can be a mixture of other lipids, phospholipids or cholesterol. If we look at the free fatty acid, mainly myristic, palmitic acid, palmitoleic acid, stearic, oleic, linolenic, these are the linoleic acid. These are the free fatty acids that will be esterified and present. So, if we look at the structure of triglyceride molecule. So, this is the glycerol backbone, and to this backbone we have fatty acid 1, fatty acid 2 and fatty acid 3 that are esterified. Most often the R2, that is the position 2, the fatty acid esterified at position 2 will be a unsaturated fatty acid. At position 3 it can either be saturated or unsaturated fatty acid. So, now let us look at synthesis of triacylglycerol. A small part of this synthesis we did look at when we were discussing about digestion and absorption, how within the intestinal cell whatever has been absorbed is resynthesized into triacylglycerol and transported through chylomicrons. So, if we look at synthesis, mainly happens in liver, adipose tissue and intestinal cells. A small amount happens in other tissues. So, we have two different pathways. The pathway seen in liver adipose tissue, and we have a intestinal pathway. General pathway for synthesis of triacylglycerols. So, we have glycerol phosphate and we have a fatty acid. These are the two prerequisites. So, one small thing to note here. So, glycerol can be converted to glycerol phosphate by the enzyme glycerol kinase. This glycerol kinase enzyme is present only in the liver. So, in the liver, from glycerol directly glycerol phosphate and then triglycerides can be synthesized. Other tissues do not have glycerol phosphate. So, here glycerol kinase to phosphorylate. So, in other tissues glycerol phosphate can be obtained from glycolytic pathway. We have dihydroxyacetone phosphate which undergoes reduction by the enzyme glycerol phosphate dehydrogenase. So, NADH is the donor of reducing equivalents and it gets oxidized to NAD and DHAP is reduced to form glycerol phosphate. So, this is happening in most tissues, whereas glycerol kinase is present only in liver. So, general pathway, either we can start from glycerol 3-phosphate, glycerol phosphate. So, to glycerol phosphate, transfer of one activated fatty acid, acyl CoA molecule. Acyl glycerol 3-phosphate, acyl transferase is the enzyme. So, we form monoacyl glycerol phosphate, or else DHAP. To DHAP also directly there can be a acyl transferase, that is addition of a fatty acid to form 1-acyl DHAP. And this 1-acyl DHAP in turn can undergo reduction to form monoacyl glycerol or lysophosphatidic acid. So, next step is addition of another fatty acid. So, monoacyl glycerol acyl transferase. So, one more fatty acid is added to position 2 to form diacyl glycerol 3-phosphate or phosphatidic acid. Now, next step is addition of, we need to add another fatty acid. So, before that the phosphate group that is present at position 3 has to be removed. So, we require a phosphatase for this, phosphatidic acid phosphatase or phosphatidase. So, removal of the phosphate group happens and we are left with 1,2-diacyl glycerol. Now, one more fatty acid is added by a acyl transferase to form triacyl glycerol. So, the phosphatidic acid that is formed here, this can be utilized for formation of phospholipids, or it can undergo further another transferase reaction to form triacyl glycerol. Now, in the intestines we have already seen this previously, we have already looked at it previously, where monoacyl glycerol was the most common constituent after digestion of lipids. So, monoacyl glycerol can be absorbed and we have free fatty acids that are absorbed, even glycerol. So, now the glycerol that is monoacyl glycerol that is present will undergo further esterification with other fatty acids to form triacyl glycerol, and this triacyl glycerol will then be packaged into chylomicrons and transported to all tissues. Now, breakdown of triacyl glycerol, again we have finished this reaction multiple times. So, I am sure all of you know of this. So, there are various isoenzymes. So, we have a hormone sensitive lipase that will be present in adipose tissue. We have lipoprotein lipase which is going to be present in capillary walls, will act on circulating lipoproteins, and then we have a hepatic lipase which is present in liver. So, for breakdown, sequential removal of these fatty acids, and if you remember, lipase will not act at position 2. So, it requires a isomerase to shift the fatty acid from position 2 to position 1 for it to continue acting. So, we have isomerase and finally, we form 3 fatty acids and glycerol. This glycerol will be transported to liver, where it can undergo a glycerol kinase reaction, or it can be converted to dihydroxyacetone phosphate and enter into glycolysis. So, glycerol kinase to form glycerol 3-phosphate which can in turn form DHAP and can be channeled into glycolysis. Regulation, again I will not go into details of the slide. So, regulation of triacylglycerol metabolism, that is breakdown of triacylglycerol, depends on hormonal regulation. We have gone through this slide multiple times. So, I am not going to repeat it again. So, insulin has a dual role. Insulin increases uptake of glucose by the cells. So, there is uptake of glucose, then increases rate of glycolysis, then there is formation of DHAP, and from DHAP we can form glycerol 3 phosphate. And insulin also stimulates synthesis of fatty acids, that is from acetyl-CoA formation of fatty acids, de novo synthesis of fatty acids. So, insulin is going to help formation of glycerol 3 phosphate as well as formation of the free fatty acids, so that both of them can be esterified to form triacylglycerol. So, coming to the next topic for today, that is fatty liver. As the name suggests, fatty liver refers to deposition of fat in the liver. Role of liver in lipid metabolism. So, liver is required for formation and secretion of bile salts, and we have seen how important bile salts are for digestion and absorption of lipids. Even the fat soluble vitamin absorption requires bile salts. Then synthesis of fatty acids, triacylglycerol, phospholipids, oxidation of fatty acids, production of lipoproteins, production of ketone bodies, and synthesis and export of cholesterol. These are some of the functions of liver in lipid metabolism as we have seen so far. So, for fats to accumulate in the liver, either the mobilization is not happening or degradation is not happening. So, in a normal liver, the amount of lipid will be about 5%. Of this, maximum will be as phospholipids and about 25% will be as neutral fats. So, if you look at the hepatocytes, here you can see that there are small fat globules, and you can see the nucleus clearly, but whereas in fatty liver you can see that the fat globule has expanded so much that the nucleus is pushed to one side and there is more fat in the cell compared to the normal hepatocyte. So, this is abnormal retention of lipids in the liver cell. Classification. We can classify fatty liver as alcoholic fatty liver disease or non-alcoholic fatty liver disease. So, to know about alcoholic fatty liver, a little bit about metabolism of alcohol. Not sure whether you have completed alcohol metabolism under carbohydrates. So, we will just see how it is. Alcohol is broken down, metabolized in the body and excreted. So, first alcohol dehydrogenase will oxidize alcohol to form acetaldehyde, and here NAD is getting reduced to NADH and H+. In the next step we have aldehyde dehydrogenase, which will convert this acetaldehyde to acetyl-CoA or acetic acid. So, this acetyl-CoA that is formed can be channeled towards cholesterol synthesis or it can be channeled towards fatty acid synthesis. And both the reactions here, alcohol dehydrogenase as well as aldehyde dehydrogenase, both these reactions are seen to produce NADH and H+. So, this high NADH to NAD ratio will inhibit TCA cycle. Okay. So, this high NADH reaction favors formation of glycerol 3 phosphate from DHAP. It favors formation of glycerol 3 phosphate. So, we have glycerol 3 phosphate as well as the fatty acids which are being synthesized from the acetyl CoA. So, these will undergo esterification to form more triacylglycerol. So, types of non-alcoholic, so this is so that is one of the reasons why in alcoholics there is excessive production of triacylglycerol and storage of triacylglycerol leading to fatty liver. Type 1, overfeeding of fat. So, here chylomicrons are increased. So, these chylomicrons are acted upon by lipoprotein lipase, which leads to release of free fatty acids. Excessive lipolysis leads to excessive free fatty acids which are transported to liver, and in the liver again re-esterified to form triacylglycerol, and then these triacylglycerol are transported through VLDL. So, in the plasma there will be increased VLDL level. So, this type indicates the type of lipids, that is the dietary lipids. Type 2 is oversynthesis of fat. Although it is not overfeeding of fat, there is excessive carbohydrates and amino acids in diet. So, all these ultimately lead to excessive production of acetyl CoA, and this acetyl CoA is channeled in towards formation of fatty acids and deposited as triacylglycerol. So, increased lipogenesis in liver and adipose tissue. So, in the plasma we see more triglycerides and VLDL. Type 3, overmobilization of fat from liver, from adipose tissue to liver. This is also called as physiological fatty acid. So, whenever there is increased utilization of fats as fuel, non-utilization of carbohydrate, for example, as we have seen in diabetes mellitus, increased utilization of fats. So, there is increased mobilization of fats, impaired oxidation of carbohydrates. So, there is less DHAP, less glycerol phosphate, decreased esterification. So, all the fats that have been fatty acids that are released are esterified into triacylglycerols in the liver, okay, and increased production of VLDL, and because fats are being utilized there can be increase in ketone bodies. So, this leads to hyperlipidemia, and ketosis in extreme conditions can lead to ketoacidosis also. Type 4, undermobilization of fat from liver to fat depots. So, this is the pathological fatty liver, that is export of the triacylglycerol that is synthesized by the liver is not happening because VLDL is not being released from liver. Could be because of a mutation leading to alteration of ApoB100. So, B100 is required for VLDL. So, if B100 synthesis is affected, VLDL is not synthesized and all this will get stored in fat. So, this is the pathological fatty liver. So, inhibition of these apolipoprotein synthesis happens with certain drugs like puromycin, carbon tetrachloride and heavy metal poisoning. So, another reason for impaired excretion of VLDL can be due to deficiency of the lipotropic factors. So, we require lecithin, phospholipid lecithin for formation of VLDL. So, lecithin requires choline and methionine. So, methionine in the form of S-adenosyl methionine is required. So, if either methionine is deficient or choline is deficient, then synthesis of lecithin gets affected and therefore export of the triacylglycerol gets affected. So, what are lipotropic factors? These are biomolecules which prevent fatty liver from occurring, that is prevent accumulation of fat. So, it can be choline, methionine, betaine, inositol, all these are called as lipotropic factors. So, any deficiency of these lipotropic factors also will lead to fatty liver. Coming to the chemical agents that can cause fatty liver, carbon tetrachloride, because it prevents formation of ApoB100 and secretion of VLDL. Ethionine is structurally similar to methionine. So, this will replace methionine during the formation of S-adenosyl methionine and therefore, the formation of phospholipids will get affected. Orotic acid blocks synthesis of ApoB100. Then with ethyl alcohol, we have just seen alcohol metabolism. There is increased free fatty acid levels, increased production of triacylglycerol, increased cholesterol synthesis, all these will lead to fatty liver. So, initially fatty infiltration continues, entire cytoplasm will be filled with a lipid vacuole. So, initially it is only a big fat vacuole that is present, but slowly this will push the nucleus to one side and there is excessive pressure on the nucleus and will lead to breakage of nuclear material, that is karyorrhexis. So, once this happens, it heals with fibrosis and this formation of fibrosis is irreversible. So, the initial stages fatty liver is reversible. So, it requires dietary modifications and it can be reversible, but once it is going to heal with fibrosis, there will be loss of function and this stage is called as cirrhosis of liver and this is irreversible. So, the liver function is lost and will lead to liver failure. So, only way would be then to go in for a liver transplant, otherwise this cannot be treated once cirrhosis has happened. Okay, so I think that finishes triacylglycerol metabolism and fatty liver. Thank you.